Certainly, because I just say one group, I am a visiting professor to Kathmandu University. I take the country of Nepal as as a small country where we can have the true data, and probably we can extrapolate the same data because it's almost neighboring country to India. And in our study, probably first study in that part of the world, and maybe it's equally true in Indian statistics as well. So what we find in our study was this atrial fibrillation in relation to structural heart disease, yes, and then non-structural heart disease. So overall atrial fibrillation, it is 35 to 38% is related to rheumatic valvular disease, and 30% is related to degenerative valvular disease in elderly patients, like calcific aortic stenosis, calcific mitral valve disease, and some 20% related to cardiomyopathies. Lone atrial fibrillation or non-valvular atrial fibrillation, where the heart is structurally normal, is probably it comes around 10 to 20%. Yes. So probably I can say this can be the same in India as well. So some 10 to 20%, like lone atrial fibrillation or non-valvular atrial fibrillation. But at least we can see in India as places equivalent to developed countries and underdeveloped. Poor. We have the two extreme cohorts. Yes. So in still the rural area, rheumatic and other valvular diseases, they prevail atrial fibrillation, and in cities, metros, especially developed states and developed cities, they are on par with developed countries where the non-valvular atrial fibrillation is at least increasing rapidly. Yes. So and relevant to how best we can detect and diagnose, the thing is, we have at least most of the educated people in India, they have the tendency of having checkups, annual checkups, yes, health checkups. And of course, in rural areas, it is it's both, professional from the doctors as well as from the policy makers, that we need to identify the patients and then make a database and then register. But sometimes patients, most of the rural population, they come with the symptoms, yes, not just because they have atrial fibrillation, because of the heart disease. So maybe chest pain, breathlessness, maybe syncope, or with established complications like stroke or any embolic phenomenon. So then atrial fibrillation is accidentally diagnosed. Retrospectively. Correct, retrospectively. And yes, in an asymptomatic patient, so at least from our professional side, the maybe tertiary care hospital at least, what we suggest, and actually we are doing, is making a registry database, and patients with non-valvular atrial fibrillation or lone atrial fibrillation or only atrial fibrillation without structural heart disease. So definitely we are lacking through registries, through data, incidence and prevalence. And how best we can detect? It's simple. It's very simple. It's the most common arrhythmia, yes, and all arrhythmias are best detected by simple physical examination, by checking the pulse as well as taking an ECG. Well, if patient says that I have palpitation once in a while, and a baseline normal clinical exam, pulse is regular, ECG is normal, it could be any arrhythmia. So the best way to detect is like 24-hour Holter monitor, or so even monitors like external loop recorder, internal loop recorder. So in an asymptomatic individual where we suspect atrial fibrillation is the cause of arrhythmia, where baseline parameters are normal, maybe the best way is Holter or even monitors like external loop recorders or internal loop recorders. That's the best way. That's the best way to detect, document, and evaluate for the further proceedings, how to treat the patient. Yes. Sure.